Aortic stenosis. Apex beat is palpable in left fifth intercostal space which is heaving in nature. Systolic thrill in aortic area. First heart sound normal. Aortic component of second heart sound is soft. An ejection systolic murmur heard all over the precordium but best heard in aortic area which is harsh, grade 4 by 6 in intensity, radiating towards both neck. The differentials are aortic sclerosis, hypertrophic obstructive cardiomyopathy, pulmonary stenosis, aortic regurgitation. Have you examined carotid pulse? Yes, I have got low volume pulse with slow rising, parvus et tardus. I have also got thrill over the carotids. Note simultaneous palpation of carotid and apex. What is Galabardin's phenomenon? In aortic stenosis, murmur is best heard at aortic area, diminishes over the sternum, reappears over the LV apex, that is high-pitched musical sound. What is carotid shudder? Systolic thrill transmitted to carotid pulse. So never forget to palpate carotid while dealing with a patient of suspected aortic stenosis. What symptoms patient may have? Exertional chest pain, shortness of breath, exertional syncope. Why angina occurs? LVH causes supply demand mismatch, reduced coronary flow reserve, reduced diastolic coronary blood flow, decreased LV compliance, increased LV and diastolic pressure, reduced diastolic gradient. 50% patients have concomitant coronary artery disease. Why shortness of breath, reduced LV compliance, increased LV and diastolic pressure, pulmonary congestion, heart failure with preserved ejection fraction. Prolonged pressure overload in LV causes relative ischemia, apoptosis and permanent cytoskeletal change, causes systolic dysfunction. Why syncope occurs? Exercise-induced peripheral vasodilation, failure to usual exercise-induced increase in cardiac output as obstruction is fixed. What may be the possible cause of aortic stenosis? Degenerative. What are the other possible etiology? Congenital bicuspid aortic valve, rheumatic. What is the hallmark auscultatory finding of bicuspid aortic valve? Ejection click, bicuspid pliable leaflet. Is it severe aortic stenosis? As I have got parvus et tardus pulse and absent A2, so it may be. Reverse splitting of second heart sound and prolonged murmur also indicate severe aortic stenosis. What are the possible complications? Arrhythmia, sudden death, coronary artery disease, congestive cardiac failure, infective endocarditis. Possible ECG findings: LBH with strain, enlarged LA, LBBB, asymmetrical T wave inversion. Possible chest X-ray findings: cardiomegaly, not in my case, with LB type apex, AB calcification, ascending aorta dilatation. Now, possible echo findings in plaques view: concentric LBH, reduced LB cavity, enlarged LA, calculation of ejection fraction, dilated aortic root in bicuspid aortic valve, degenerative, measured at diastole, thickened and calcified RCC and NCC with restricted opening at systole, annual calcification in degenerative etiology, eccentric closure line in bicuspid aortic valve in M mode, reduced ACS in M mode. Parasternal short axis view, thickened leaflets with a restricted opening at systole, commissural fusion in rheumatic etiology, small triangular systolic orifice, ellipsoid systolic opening in bicuspid aortic valve, reduced atrioventricular AV area, measured in systole, zoom view. Apical 5-chamber view shows peak jet velocity, mean gradient, LB-OT diameter and VTI. Note, site of color flow aliasing. Flow acceleration can differentiate valvular, subvalvular or supravalvular aortic stenosis. What are the echocardiographic parameters for severe AS? Severe calcified leaflet, congenital stenosis with severely reduced leaflet opening, aortic valve area less than or equal to 1 centimeter square, peak velocity more than or equal to 4 meter per second, mean gradient more than or equal to 40 millimeter mercury, Doppler velocity index less than or equal to 0.25, aortic valve area index less than or equal to 0.6. What are the normal and abnormal SCS in M mode? Mild aortic stenosis, it is 12 to 16 millimeter. Moderate AS, 8 to 12 millimeter. In severe AS, less than 8 millimeter. Why LV dysfunction in aortic stenosis? Concomitant coronary artery disease, cardiomyopathy, long standing untreated severe AS. Few terminology: high gradient aortic stenosis, peak velocity more than 4 meter per second and mean gradient more than 40 millimeter mercury. Low gradient aortic stenosis, low flow aortic stenosis is SVI, that is stroke volume index, less than 35 ml per meter square. Reduced ejection fraction means in case of aortic stenosis it is less than 50%. In true severe aortic stenosis, LV systolic dysfunction is due to long standing aortic stenosis. In pseudo severe aortic stenosis, LV systolic dysfunction is due to coronary artery disease or cardiomyopathy. What is presence of contractile reserve? It means low dose dobutamine increases stroke volume by 20%. What is the clinical significance? Absence of contractile reserve is associated with higher surgical mortality, 30% versus 10%. What is the role of dobutamine stress echo? To differentiate true severe aortic stenosis from pseudo severe, to determine the presence of contractile reserve. When will you go for coronary angiogram? Age more than 40 years with angina, don't forget about coronary angiogram. Is there any rule of cardiac catheterization other than coronary angiogram? Yes, sir. Transvalvular pressure gradient is measured across the aortic valve by using a catheter in LV and another in the proximal aorta or femoral artery. A mean pressure gradient more than 30 millimeter of mercury usually represent clinically significant aortic stenosis. When there is discordance between clinical feature and non-invasive data, aortic valve area can be measured using the Gorlin formula, LVgraphy, root aortography. What is the medical treatment? No proven medical treatment. Treatment of concomitant hypertension, vasodilators, start slow and go slow. Infective endocarditis prophylaxis. Is there any relationship between calcific aortic stenosis and coronary artery disease? Calcium embolization in coronary artery. How will you follow up your patient? Mild aortic stenosis, 3-yearly echo. Moderate aortic stenosis, 2-yearly echo. Severe aortic stenosis, yearly echo. In exam, patient is either symptomatic or asymptomatic severe. What is the definitive management? Surgical aortic valve replacement. What is the indication of aortic valve replacement in symptomatic severe high gradient aortic stenosis? Symptomatic severe low flow low gradient aortic stenosis with reduced LV ejection fraction and evidence of contractile reserve. excluding pseudo-severe AS. Asymptomatic, very severe aortic stenosis. Asymptomatic severe AS with LV dysfunction undergoing another cardiac surgery. Exercise induced deterioration, that is symptoms and hemodynamics. Is there any rule of intervention? Yes, sir. When patient has indication of surgical aortic valve replacement but not suitable for surgical aortic valve replacement due to high surgical risk assessed by heart team, partner and notion trial. What are the types of prosthetic heart valves? Mechanical, bileaflet, biological, stented porcine, stented pericardium, stentless, sutureless. What is the operative mortality? 2 to 4% in most registries, but when associated with CABG, mortality increases to 10%. What is Ross procedure? Transplanting the patient's own pulmonary valve into the aortic position and replacing the pulmonary valve with a homograft, assuming that it will be more durable in the low pressure pulmonary circuit. Is there any rule of balloon valvuloplasty? Yes, sir. It may be considered in congenital bicuspid aortic valve with pliable valve leaflet or in pregnancy with symptomatic severe aortic stenosis. Contraindicated in calcified aortic stenosis. Tell me about the prognosis. Angina 5-year survival 50%. Syncope 3-year survival 50%. Dyspnea 1-year survival 50%. Echocardiographic overestimation when associated with aortic regurgitation. Echocardiographic underestimation when associated with mitral regurgitation. Difference between mechanical valve and biological valve. Mechanical valve 10-year survival is 70 to 85%. Biological valve 10-year survival 20 to 85%. No structural valve deterioration in for mechanical valve. For biological valve 25 to 40% has structural deterioration at 15 years. Thromboembolism 20% at 10 years. For biological valve it is 10% at 10 years. Major hemorrhagic events 10 to 20% at 10 years. In case of biological valve, it is 5 to 10% at 10 years. Reoperation risk 2 to 5% lifetime for mechanical valve. In case of biological valve, it is 25 to 40% lifetime.